Morning, folks.
How are you? Thank you
Very nice to
for
see you. Are you safe in New York?
yeah, we're okay. It's snowing now. Can't even
Okay.
compare to Florida.
Yeah, well, it's good. We're getting a little bit cold, but it was 90 on Friday.
Oh my
Imagine
God.
that.
That's incredible.
How are you?
Hi, I'm Jim in Seattle.
Nice to see you. Jami Kinnucan, down in Jacksonville, Florida.
Hi, Dr. Kinnucan. My name is Gloria. Oh, let me actually change my first name. I'm the secretary currently, and then thank you so much for your flexibility for our time arrangement.
Yeah,
Appreciate it.
absolutely. Do you want me to see how well I can share my screen?
Of course.
Perfect. Sharing is not turned on.
Oh, sharing is not turned on.
Yeah, I think
Oh, okay.
you just have to change the
Um,
settings.
yeah, I had to have Dr. Son change the setting. I believe he should be in here already.
Yeah, I see them.
Yeah, he may assign you as the speaker or the co-host, and then you'll be able to share.
Right. Oh, Dr. Dr. Yichen, I think you're muted.
Oh, okay.
Oh, not. Oh, I think he changed me to one of the hosts. Let me just see if I can. Okay. Oh, okay. Dr. Kinnucan. I
Yes,
want
good
to
job. It's
Kinnucan.
not an easy one.
Yeah,
All right,
thank
let me
you.
know if you can see, and then I'll get it into present.
Yeah, it's popping
Yep.
up now.
Yeah,
Looks like
I
it's
changed you
sharing.
to co-host. Alrighty.
Wonderful.
And if you want to just let me know if when you plan to get started.
Hele.
Yeah.
Huh?
Yeah, Yiling, let's start.
Yeah, okay, of course. I think we're ready for you.
Yeah. Can you do some introduction? Yeah. Yiling?
Yes.
我已经 log out.
Dr. Shen, would you like me to introduce Dr. Kinnucan, or would you like to?
Yes, please.
Oh, okay. So everyone, today we're really honored to invite Dr. Kinnucan, who is currently a gastroenterologist, practice in Mayo Clinic, Florida. She is the associate professor of medicine in the division of gastroenterology and hepatology.
Please quiet.
Oh, sorry about that. And then most importantly, she's also the associate chair for practice and the systems transformation for Department of Medicine. And then previously, Dr. B, one of our steering committee member, mentioned that she learned greatly and benefited greatly from Dr. Kinnucan's coding practice, and then to how to increase the coding in the GI practice. So we are really honored to have this opportunity to invite Dr. Kinnucan to give us this talk on this topic.
Well, I appreciate the steering committee and the organization for having me. Hold on one second. Yes, you can record. So thank you for having me, and I'm so glad to see almost 30 people out tonight to learn a little bit more about how they can optimize their billing, which ultimately, whether you're in academics or private practice, can impact your bottom line in terms of either your organization and or your take-home pay. Certainly in private practice, underbilling can lead to significantly less revenue for your group. And then if you're in an academic practice that's using RVUs, which we'll go over, then it could also impact potentially the salary that you take home. So this does have meaningful benefit to your practice, and so I'm glad to see everyone here today. All right, and so what are our learning objectives for today? So we're going to differentiate when to bill based on medical complexity over billing based on time. And a little bit of a kind of a trick I'll teach you, which is always go for time first. And if you don't get your maximal billing, then we'll move on to medical complexity. So you don't have to remember some of the complexities, no pun intended, around the medical complexity billing. We're going to identify opportunities to bill for asynchronous, some of the things that you may be doing in your practices or may not be. And so there's some opportunity to be billing for some of the work that right now is not necessarily reimbursed. And then recognize opportunities for enhanced billing and endoscopy coding. So, of course, a disclaimer here is that I'm a clinician who spent some time learning about the details about reimbursement and billing. I went from fellowship into practice and realized I knew nothing in terms of how I was going to be getting reimbursed or how I was going to be submitting for billing and my practice. So I do recommend, though, after this talk, before implementing any changes, major changes, maybe new CPT codes that you've not been billing for, that you should work with your compliance and your billing team because they may have some regulations or compliance around that within your organization. And then, in addition, some reimbursement can be very geographically driven. And so we're joining from all over different parts. And so it's important to work with your main payers on specific changes. You'll see throughout the talk some pearls. These are just kind of some high yield tips to watch for the little yellow sticky note. Sorry, going backward. So we're going to first start with clinical billing. From an outline, we're just going to get back to basic terminology because I'm going to be going through different things throughout the talk, and I want to make sure that we're on the same page. We're going to talk about current billing requirements for evaluation and management services, knowing that there were some changes that happened about 5 years ago in 2021. We're going to talk about complexity and prolonged service billing, so things when you go above and beyond sort of those basic billing codes. People always ask, what's the difference between, E&M service billing and consultation billing? And I'll talk through that a little bit. Talking about asynchronous care billing, really in the form of e-visit, and we'll talk about those CPT codes. And then whether or not your practice has really thought about introducing chronic care management code billing and how that can help with longitudinal care, especially in complex patients like what I treat, which is inflammatory bowel disease. So maybe you guys can put this in the chat if it's turned on. What is the single most, or you can, for those that are able to unmute, what is the single most important aspect about submitting billing codes? The most important thing, number one. Anybody can take a stab at it.
Is it insurance the payer paying?
Yes, we always want to get paid, but how do we make sure that we get paid for what we're doing? The most important thing that you can do is document. So if you did it and you didn't document it, you're not going to get paid for it. And so there are estimates that up to 80% of medical bills, things that we are putting out there, actually contain some form of error, either overbilling, underbilling, not documenting with the things that we presume we're billing for. So this is something that's incredibly important. So documentation is really important. And of course, with generative AI and that type of documentation, we are able to capture more of that conversation we're having with patients, but it's not necessarily capturing the amount of time. And I'm going to tell you that time-based billing is going to be sort of your default, and then we'll go to medical complexity billing if we're not meeting time-based billing. So just billing terminology, kind of the ABCs here. So we have work RVUs, we have practice expense RVUs, and we have malpractice expense RVUs, and that, when you combine them, equals your total RVU, which is typically then times by a conversion factor, which then gets you your payment rate. So what is an RVU? It's a relative value unit. It measures the amount of provider work. An RVU is typically tied to a CPT code. A CPT code is a current procedural terminology. So even though it says procedural, we do use it on the clinical side. So a CPT code for a visit type is a 99214 or variety, which I will go through. Government insurance typically pays less per RVU and definitely is geographically tied. Commercial insurance pays more, typically per RVU. You can have consult-based codes and you can have non-consult-based codes. And then when I'm saying E&M, it's an evaluation and management service, and that's typically talking about what you're doing on the clinical side. So this is kind of our basics. Oh, sorry. We don't want people to make this common billing mistake. So you don't want to be submitting for a lower level of service than the medical decision-making or time that you did. We certainly don't want you submitting a higher level of service than the medical decision-making or the time. Lacking, again, that appropriate documentation. Over-documenting, cutting and pasting from every note for the last 20 years doesn't necessarily get you more money. Copy and paste errors. So when you're copying things forward, let's say instead of having an automatically updated medication profile, you cut and paste something from the last visit where those medications have changed. Delay in billing. Typically, payers will not pay or reimburse within certain times, and that's very geographic dependent and payer dependent. And not necessarily using the tools that are available to you. So I know everyone's probably coming from different systems. The number one electronic health record that's used in this country for documentation is Epic. And so Epic has an EHR billing calculator, but some of the other less frequently used EHRs also have billing calculators. So you don't have to memorize all of this. So if you remember billing, and many of you may not remember billing prior to 2021, there was this previous billing. It was based on your history, your physical exam, and medical decision-making, or it was based on time. Some things changed in 2021. Documenting your history was no longer required for billing. Documenting a physical exam, thankfully in COVID, that mattered, was no longer required for billing. And really, sorry, that animation kind of got funny. Really what happened is that medical decision-making and time became the two ways that you can bill. And if you meet the highest level of billing based on time, you shouldn't even think about medical decision-making because you've already captured the highest amount of billing and even maybe prolonged service codes, which are only associated with time-based billing. And so really focus on, did I spend enough time to reach that maximal number? And if the answer is yes, then you move on. Or then you bill and you move on. You don't even try to calculate your medical decision-making. So we'll go through that. I'm going to give you an example of something that you may see in your practice, and we'll think about it both ways. 45-year-old female, ulcerative colitis, well-controlled on biologics, combination with an immunomodulator. It's not really as common in our practice as much anymore, but comes for their 3-month visit. Part of this, I reviewed the prior outpatient note. I reviewed recent labs and stool testing. The patient requires every 3-month lab monitoring on an immunomodulator. I reviewed images from the colonoscopy that was performed by one of my partners. I reviewed the pathology report. I placed orders for lab, DEXA vaccinations. I consulted dermatology for a skin exam. I spent a total of 20 minutes with the patient and 10 minutes documenting and coordinating this care and orders on the day of the visit. So we're going to go through billing for this particular patient. So option one, again, billing based on time. This is where you're going to go to first. Did you meet that maximal billing? So again, prior to 2021, it was based only on the time that you spent face-to-face with the patient. And so for those of you that were billing and having to document, you remember having to document, I spent X number of minutes face-to-face with the patient. After 2021, no longer do you have to just focus on face-to-face time. They actually are appreciating the work that we do outside of the clinical visit, the things that we don't do face-to-face with the patient. So not only does your face-to-face time count, but your non-face-to-face time counts as well, but only on the day of the encounter. So the day that you spent, the day before that visit that you spent prepping for that clinical case does not count for the time that you spent on the care of that patient on the day of the visit. So this can be non-continuous time. So maybe you prep all of your patients that morning, and then any patient you see the rest of that day is going to be part of that time you spent for that particular patient. So what qualifies as this? So again, prepping to see the patient, review of records, obtaining a history outside of the visit. Maybe you got a phone call from the colorectal surgeon. Medical appropriate examination counts. It's obviously face-to-face. Counseling and educating the patient, family member, and caregiver. Ordering medications, testing, and procedures, whether the patient is sitting in front of you or not sitting in front of you. communicating with other healthcare professionals, again, whether you're calling, maybe you're calling your colorectal surgeon to give them an update after the visit. Documentation, yes. Writing your note and documenting your note counts towards your time. Independent review of testing, and then care coordination. So typically, if I'm going to do a prior authorization and I'm going to have to do, a note, which is made significantly easier in the setting of open.
Estoy en una conferencia importante de billing.
That person who unmuted. And so I typically do my prior auth on the same day of the office visit with the patient, because again, that time that I spent qualifies for the time-based billing. So I really rarely use medical decision-making billing, but we're going to go through this particular case. I'm so sorry. I'm getting a little roller happy. So what are these new time requirements, since we're talking about time? So these are your level of service, new patient 2 to new patient 5. In 2021, new patient 1, level 1s went away. And these are your level of service for your established patients. This is somebody that's been seen within your practice within the last 3 years. And these are return 2s to 5s. And you can see the codes right here. You don't need to memorize these. These should be baked into your EHR. But anything that ends with the 2 is obviously a level 2 to a 5, level 5. These are the previous time commitments that were required prior to 2021. And this is now what we need for total time with the visit. So if I'm seeing a new patient in my practice, I have to spend 60 minutes to reach a new patient level 5 with them. And that's in person with me. That's doing that documentation, that care coordination, and any prep or post-visit work that I do. And then in a return visit, to get the maximal level of billing, I need to spend 40 minutes with the patient and any care coordination of that patient. So now thinking back to our example, based on time-based billing alone, I spent 20 minutes with the patient and I spent 10 minutes doing care coordination. So that would only qualify me as 30 minutes with that return patient. And so I'm able to bill an RV4 if I bill based on time. I'm not happy with that, because I know that that patient is a complex patient and likely will meet criteria based on medical decision-making. So I'm not going to bill the level 4. I'm going to go back and see if I qualify for a higher level of billing with medical decision-making. So again, wanted to talk about kind of that billing calculator. This is a screenshot of my level of service buttons that I have. I've plugged these all in. I've created them. Normally, they will look just like the CPT code. So you can actually use your little rents right there and you can make them look nice and pretty like these. And then you can use this little wand, which is actually a medical decision-making calculator. And then typically in level of service within Epic, once you've opened that encounter, it starts a tracker. When you're actively engaged in your chart, it'll give you a little time down here. The reason this is not screenshotted from an active live visit, but there's a little time ticker down there. And if you just click on it, it'll auto select the right billing code for you based on time. Now, if you walk away from your computer, it doesn't capture that. But if you leave it open and then you go to another record and back and forth, it may be not as accurate as the time. So you have to just keep track of when you're actually in the chart. This shows you the wand where you can actually open this level of service calculator. And the only time I'm using it is I like it for the medical decision-making if I feel like I need that. And I'm trying to capture, again, the highest level of billing based on the documentation and the time I spent, or not the time, but the complexity of the patient. Sorry. Okay, but what happens when you spend more time than an allotted amount? So let's say in that new patient visit that you had and you spent 80 minutes with that new patient visit, you can build prolonged service codes. And this is usually when I have given this talk in different organizations. Most of the time, people aren't aware of these prolonged service codes that they can bill from. It's baked into our Epic. And so when I spend, if my ticker says 90 minutes or 80 minutes, it's billing the highest level, a new patient 5. And then it's also then adding on the prolonged service codes. And typically you can add on up to 15-minute increments, as many as you qualify for. Commercial, the coding is a 99417, and under Medicare, it's a G2212. And these should be in your EHR. And so each additional 1 to 15 minutes spent can qualify. So if I saw, again, if it was 90 minutes, it would actually be, and I think there's somebody coming in with the chat, 90 minutes, I would get 1 prolonged service code billing. Let me see if that's something. If you're not on Epic, many EHRs, and I couldn't possibly go through all of them, but you could be welcome to email me. Many EHRs have something built in to your your billing area of your EHR that is either auto calculating the time that you spent. Not all though do have that. So if you know that the visit was 30 minutes, it started at this time and ended at this time, and you know you did about 5 minutes of work beforehand and you did 5 minutes of work after, you know that you reached your 40 minutes, you just need to document that you spent your 40 minutes. If it's not baked into your EHR, that you have to do that documentation. When it is baked into your EHR, it is included as part of the documentation when you sign your encounter. Many people still document at the bottom, I spent 40 minutes in the care of this patient, but you actually don't have to from a compliance standpoint, because as part of that encounter, when they submit it, it's actually automatically included in there. But then again, you can only bill based on the time that you spent on the date of service. This is the primary encounter, again, based on time for prolonged service. So you reach the highest level and then you even did more work. This is where you can get this. And this is where it's actually helpful when I do my prior authorizations the same day, because typically it takes time to put together the workflow, the letter that's going to be going to the patient. Maybe if I call an insurance company on the same day of a visit, that I'm going to be able to bill for the time in that situation if the patient had an E&M on the same day that I called the insurance company. Okay. Sorry, the mouse is a little bit off. Okay, understanding complexity of care. So I haven't gotten to medical decision making yet. We're still focusing on time. So complexity of care, there is a G2211 billing code, and we use this actually quite frequently in our practice, especially in our patients with inflammatory bowel disease. So the code gives credit to complex, high-value visits as part of a continuous relationship with the patient. So if you are following a patient longitudinally in your practice, the intent is not to do a one-time visit and then send them back. They still may be complex, but that you're going to continuously follow this patient. You would bill a patient that has a complex high-value visit with your standard billing code for your, let's say it was a new patient or a return patient, plus you would add this G2211, which can increase the amount of reimbursement that you have per visit. You can see the information for this right here. So you can add this in addition to both your new and your return visits. You cannot use this with the 25 modifier. When do we use a 25 modifier? If I do an intestinal ultrasound on a patient that I am seeing in clinic, I bill their clinic visit plus a 25 modifier. I'm going to go through some modifiers with you in the next couple slides. But I can't do the G2211, and I get pharma reimbursement when I'm doing my intestinal ultrasound. So I'm going to do my 25 modifier and bill my ultrasound and my visit in the same day. In some EHRs, this can be automated. Right now, it is not automated with our using of Epic, but you could ask your EHR leadership if there are certain billing things that are automated based on a specific ICD-10 code that's put into the visit diagnosis. All payers, both commercial and government, pay for this, but the coverage of this code varies. When I send these slides to the organizational leadership, each of these blue hyperlinks will take you to more information about using these codes in your practice. Okay, so any questions before we move on from time-based billing? So it's easy. It's the amount of time you spent the day in the care of the patient, both face-to-face and non-face-to-face. And if you meet that maximal time, bill that time and move on. But what happens when you don't meet that level of code billing time? That's when you're going to move to MDM. So I'll give a pause so people can ask questions about time-based billing. Otherwise, we'll move on to
Jami.
Yeah.
Jami. So we have for IBD patient, right? It's like longitudinal care, and let's say that every 3 months, 6 months they come back. We build up the established patient, and your last slide said you can build additional because of long-term relationship.
Well, it's that the intention is to have a continuous relationship with the patient. So even when I see a new patient to the practice, many times we're seeing a patient as a consult from the community, and we are going to provide guidance and then send them back to their local team. Those I cannot bill a G2211. But for the patients that are establishing care, and so what I'm documenting in my record and my documentation is obviously the complexity of the illness, which is defined by the ICD-10, but that the patient is establishing care within the practice. So the intent is to have that continuity relationship with them.
So you can use the code G2211.
G2211.
Yes, I see. And that you also means meaning it's a non-physician provider. That means nurse practitioner or my secretary.
Nurse practitioner or a physician assistant.
I see. Okay, great. Thank you.
Can I ask you a question?
Yes.
Yeah, how you document the time for documentation? Because some people use Dragon, some typing. So how you use that?
Yeah, so I think it all is dependent on sort of from start of that experience for when you opened up that record, started your record review, when you were in person with the patient, and then whatever time you spent. I don't spend quite a bit of time on documentation anymore using a program called Abridge as my generative AI documentation system. So I'm spending less time documenting. And so I have had to kind of look at a little bit more of my medical decision making because I am spending less time doing some of the work. But you again, depends on your EHR. If your EHR is automatically calculating time in the background and that's what you're using to submit for your billing, then you don't necessarily need to document, I spent 70 minutes in the care of this patient. And that's really what you need to document. You used to say I spent, so the accurate documentation was I spent 70 minutes in face-to-face and care coordination of this patient on the day of service. And then that's where you're documenting your time. So that would be at the end of your note, and then you're going to sign it. Did that answer your question?
Yeah, for the established patient versus new patient, so your time for documentation probably different. So do you have like a standard time and like 10 minutes for follow-up and like 20 minutes for new patient? Do you have any like ballpark how you document your time? Just
No,
for
I mean, I'm
documentation
documenting the
itself.
time I'm spending. So when I'm in the record, I have an automated ticker. I know that some individuals, when they don't have that built into their EHR, have used just a timer if they're typically billing based on time. But I don't have anything that I'm particularly using outside of what's already built into the EHR, which is calculating the time I'm in that record. So when I'm sitting with the patient and I'm documenting and I'm putting in orders and I'm talking to them and the dictation system is running in the background and I actually can see how long the visit is just based on my dictation system. Because I have the second I turn it on and the second I turn it off, it tells me how long that visit is. So that in addition, so if you didn't have it built into your EHR and you were using one of those ambient listening devices, it's going to tell you how long that recording is. That could be one of the ways that you say, okay, that was 32 minutes. That's the recording that it is. I typically turn my dictation on as I'm reviewing records too. So I'm able to speak into the dictation and it's capturing last colonoscopy showing X, Y, and Z. So that's adding to the time. So that's another way that if you had access to the generative technologies, that could be calculating time for you. But I don't have necessarily kind of a guesstimate. When you are billing based on time, you of course want to be as accurate as possible.
Okay, thank you.
All right. Yep.
There's another, sorry to interrupt. There's another question in the chat from Dr. Kumar. Would you like to continue the presentation or answer the question for now?
Yes. So the G2211,
Yeah.
I believe that reading that I give you, hold on one second. Let me go forward. Reading that I give you will give you other will give you other ideas of other patients that you can use that are kind of how do you understand and how do you capture complexity? Like what is defined as complexity? I gave inflammatory bowel disease, that was an easy example. I'm not sure, I'd have to look through if GERD qualifies, but longitudinal relationship with complex patients with long-standing irritable bowel syndrome that's maybe not controlled, or those patients with more motility issues. Would also be, easy qualifiers. Patients that are post-transplant or have chronic liver disease would also be patients that could qualify. Thank you for that question. And I can see if there's a list out there of other potential examples within the GI space.
Yeah, I keep a standard statement in my Dragon dictation to insert it whenever I use G2211. It's for complexity, but also for continuity of care. If you plan to see the patient back over and over again, cirrhosis, IBS, IBD, you can apply G22. There's a standard language you should use, and you can figure that out and put a standard language in your dictation and just insert it without having to type it every time.
Yes, thank you, Jim, for that follow-up too. And this resource here that's linked at the bottom will also give you some ideas of ways that you can adopt that for your particular patient population that you see.
Can I have a question, please?
Yeah.
So let's say if your ENM code is 99213, and if your bill on time is 15 minutes. So if you spend 30 minutes, you will bill 99214, right? You don't use
Yeah,
the
if you were spending on a
G2211.
return visit, you would do a 99214 if you spent 30 minutes.
So really, this code is applied to the highest level of ENM code. Then you add this code.
Yeah,
Because
so
otherwise
you have to spend the max. So you have to spend 54 minutes in a return visit to add the prolonged service code.
But not for the 2211. 2211 does not have to go to the highest amount of time.
Yeah, you can
It
add
can
it
be added to any code.
Yeah, this is any code. The code that matters is the prolonged service code. This one is where you have to spend the max time and then you get extra credit for spending more time. But the G2211 can go on any code, no matter how much time you spent. That was a good question.
That's very helpful. Very helpful.
So now we know if we're going to bill based on time. But if you don't meet those maximal billing codes, is there an opportunity to capture the complexity of that patient using medical decision-making billing? So again, either bill based on time or medical decision-making. Never both. So again, the calculator is built into many EHRs. So what is medical decision-making based on? Well, it's based on three important things that together make up whether or not you qualify for medical decision-making complexity. So it's based on problems, the number of problems you address during the visit and complexity of those problems, amount and or complexity of the data that you reviewed and analyzed, and risk, the risk of complications or morbidity or mortality in that patient's management. Now, you don't have to meet all three. You just have to meet the two highest. And so let's give you some example. Let's go back to, thinking through our example. So we've got medical decision-making based on problems. This is based on quantity and complexity. So here are some examples throughout. So right now we were saying we already got to 4. So the question that I have for myself, and I'm going to use my calculator for this, but if you just wanted to print out this slide deck, what's going to get me to a level 5? I already know I made a level 4 with billing, but I want to know if I'm going to get to a level 5. So I need one chronic illness that currently is in severe exacerbation, progression, or treatment side effects. So somebody who has inflammatory bowel disease that's not doing well, somebody with irritable bowel syndrome that is coming in that is symptomatic, or one acute or chronic illness or injury that poses threat to bodily function. So somebody that's really sick that's sitting in front of you. So my sick IBD patient that's in the middle of a relapse, this patient is automatically a level 5. The patient I saw, the example was not. The patient was doing well. Patient that's coming in is saying that they're having side effects related to their treatment. That's a level 5 based on that. So problem, it's a little bit harder in the problems category, unless the person's just really not doing well in front of you. And that was not the example I gave you of my patient. So tests, what matters here? Outside records, testing within basically anything that has been done to this patient that you've reviewed, independent interpretation of tests. So not only are you going to do this, so you opened up the CT enterography, you reviewed it, but you also documented that you did that. Just because you did it, if you don't document it, you're not going to qualify here. And then discussion with other health professionals. So data billing based on data, category 1 is any combination of 2 of the 3 of these. Review of external notes, you probably do this for each of your patients. Review of results from a unique test, you do this. So any combination right here. Ordering of tests, I did that in that visit. Assessment of requiring independent historians. They bring a family member along with them, or maybe they have a caregiver that's coming with them. Category 2 is independent interpretation of a test performed by another physician or a qualified healthcare professional. So this would be an example of my partner did the colonoscopy. I opened up the images, I reviewed them. I said it looked like a Mayo 0. But again, it's documenting that I independently interpreted the following testing. And then category 3 is discussion of management with an external physician or other qualified healthcare professional. So you discuss the case with somebody, related to the care of that patient. A level 4 is one of these 3 categories, but I don't care about a level 4 because I've already made my level 4. I care if I can get to a level 5, and we're going to go through my example and see if I was. So let's go back to that example. Oh, sorry, I'm having some. Okay, so I reviewed external notes. I reviewed each unique test. I ordered some tests, and this particular patient, I don't believe, had an independent historian. I interpreted the colonoscopy that was completed by my partner, and so I did 2 out of the 3. Doesn't even matter about the 3rd one. I did the work, I had to document it, but now I've met level 5 based on data. So I need 1 more category. I didn't make it based on problems, made it based on data. So we had to go to risk. So diagnostic testing, procedures, social determinants of health, the medications that the patients are taking, and whether or not that patient ends up as an outcome of a hospital or ER. That is what goes into risk assessment. So there's minimal, which we don't care about. I want to focus on high risk because that's why we're doing this. But just so you know, it qualifies as a level 3, outpatient drug management over the counter. Decision for minor surgery without risk factors. That would be like, I decided that the patient needs to have an upper endoscopy, but they are otherwise healthy. Non-cardiovascular imaging ordered, physical therapy, and occupational therapy. So we meet level 3 for almost every patient that comes into our practice, right? Level 4, prescription drug management. So you wrote a prescription for that patient. That's also majority of the patients that are probably in your practice. Patient that's undergoing EGD but has some risk factors. That's a lot of our colonoscopy patients, right? Outside of their age, the other risk factors might be cardiovascular, pulmonary, obesity is considered a risk factor. Decision for major surgery without risk factors. I'm really never making those decisions. This is probably more for the surgeons, but maybe some of our advanced endoscopists would qualify in some of the work that they do. I would say that a lot of what Dr. Shen does would probably qualify for major surgery, although it's endoscopic. And then diagnosis that's limited by social determinants of health. But here's what I really care about. Can I meet the second goal by level 5? So drug therapy with intensive monitoring for toxicity. What does that mean? I am doing some monitoring on this patient in my practice every 3 months. So any patient who is in our practice on an immunomodulator, an S1P, a JAK inhibitor, those are the typical ones. Any immunosuppression is usually 6 months for us, but those particular ones are every 3-month drug monitoring as part of a protocol. So this patient meets that criteria. Major surgery with risk factors, emergency major surgery. This is really not stuff we're doing in our practice. Decision for hospitalization, that's often decisions that we make. And then in my GI practice, I'm not typically doing this, but DNR and de-escalation of care to poor prognosis. Probably more of our hepatology colleagues are dealing with some of these discussions. So this would qualify. So I met the criteria because I have a patient on a medicine that requires frequent drug monitoring. So I met 2 of the 3 categories, data and risk. And so I qualified for a level 5 based on medical decision. So this is what the calculator looks like in Epic. And I do appreciate that many of you do not have Epic, but the ones that do, just so you see it, and you can just click through all of these and you'll automatically then output your score, which is great. So let's revisit this example. Time-based billing, I got myself a level 4 return visit. I didn't add my modifiers on here because I would also be billing her for a G2211. Based on my medical decision-making billing with data and risk, I got to a level 5. So I didn't get there on time, so that's when I jumped to my MDM and I got there with my level 5. So then I would have billed a level 5 for this patient with appropriate documents. Anybody have any questions about those comparisons for this example?
I have a question. So discussion with other provider, does it have to be a phone call or text message?
I think it has to be communication, and you just have to document that you communicated with them.
Also, the independent interpretation of tests performed by other physicians, does that have to be outside your specialty, or you can include your other doctors' procedure picture?
It can be just, it's not something that you did. Somebody else did it and now you're reviewing it. So like a CT enterography, I didn't do it, I didn't read it. However, my intestinal ultrasound, if I did it on the same day, would not qualify. But if I did it on a different day, I don't actually know the answer to that, if it would qualify. I'm rarely using MDM-based billing. I'm going to be honest, I'm using more time-based billing because of the time that I spend. But I also get more time in my practice than maybe other practices that are out there. so that time can qualify. But
So-
it's just documenting that you independently interpreted the results of this study.
So we share patients in our practice quite a bit, and many times when patient comes back to see me, the colonoscopy or EGD is done by one of my partners in the same medical clinic. When I look at the pictures, I interpret it myself. Would that be considered independent interpretation of another provider's work,
Yes.
even though that provider is in the same medical group?
Yes, so when my partner did the colonoscopy on this patient, I independently interpreted the results of it.
Thanks.
But you have to document it. I independently interpreted the results of the CT enterography done on January 2024 with the following findings. And I usually then put the report in there unless I disagree with whatever the report was, that I would put my own interpretation. All right, great questions. Okay, so I have another example, 2.0. 45-year-old patient, ulcerative colitis, well controlled on a biologic combination with immunomodulator, very familiar to our last one, and has concerns about long-term effects of combination therapy. I spent 50 minutes with this patient and then 10 minutes outside of the visit for a total of 60 minutes. I would bill this patient for a return RV5 and then a prolonged code because I spent more than the maximum for that return, which is 54. If I billed this patient based on MDM alone, I would have only gotten my level 5. I would have missed out on the opportunity for prolonged billing. The prolonged billing can only be done when you do time-based billing.
Jami, you
yeah.
can build either, but not both, right?
Oh yes. So in this one, I would only, in this particular example, I'd be billing based on time.
Okay, so you can either build either, not both. I'm sorry.
No. I'm billing a 99215 plus
Okay.
a 99417.
I see.
I'm billing 2 codes on this particular
I
patient.
see.
I think what Dr. Sen was referring to, you can only bill by time or by complexity. You cannot mix the two together.
Yes.
Correct. Oh, thank you.
And when you bill by time, you can use the overtime code,
Yes.
the 2212. If you do by medical complexity, and then you can do the 2211 at any charge level.
Yes. That's a great summary, Jim. Okay, 25 EM modifier. It's added to a consult with a procedure performed the same day. So an example in the clinical practice is I do an E&M code at 99215, and I did an intestinal ultrasound on that patient. When I'm billing the 99215, I bill the 25 modifier, and then I'm also submitting a code for the intestinal ultrasound that same day. In inpatient, you cannot bill for a daily progress note on the same day as a procedure, except the day of that initial consultation, the day that you decided that you wanted to perform. Like, so we see a new patient today for GI bleeding. We wrote the initial consultation note and we did the EGD today. But tomorrow, if I didn't do the EGD today, I would be billing on the inpatient side for just the EGD. I would not be able to bill for the progress note. We'd write a progress note, but we're not able to submit a bill. Most compliance in the hospital, most people probably are co-billing. Most people are co-billing, but but on the back end, they're just removing it for you if you double billed for a procedure and a daily progress note on the same day.
And for the office procedure, when you do a consult or follow-up, you did an endoscopy to look at hemorrhoids or whatever, that would be a modifier 25 for that
It would
procedure.
be a modifier 25 if you also are billing 992 whatever.
The E&M codes, yeah.
Yep. Okay. Consult codes, brief on this because I want to have us spend the last about 10 or so minutes talking about endoscopy. So consult were reimbursed at a higher level than non-consultation codes. They're not reimbursed by all payers. EHR is smart, and most EHRs are smart. I know that ours is smart enough. It'll suggest when my patient has a payer that can pay a consult code. Doesn't mean I'll do it, because you can see the total time is different than the time that the total time that you would have spent billing a new patient code. You can use a prolonged service code, do these consult codes when you bill based on time, but it's over 70 minutes. What's required? So this is really when you're going to do time-based billing, but it does require more time. You have to say that the patient's coming in for a requested consultation of whatever symptom or disease state. And if you bill based on medical decision-making, you also have to have a medical appropriate examination. So you have to use higher amount of time to get paid more on a consult code. And if you're doing medical decision-making, you also, in this case for consult codes, have to have medically appropriate examination documented. Asynchronous reimbursement. So these are codes, and this was an article that one of my trainees and I wrote together. It was in the 2023 of the AGA New Gastroenterologist. And I'll put a hyperlink. I thought there was one on there. I'm sorry. But this is the types of codes that you can bill for the care that's happening in between care. This is where you should talk to your organization to make sure that they have all the things that need to be in place to compliantly do this. An e-visit care. So the patient writes you a portal message, not writes you back, but starts a portal message to you. We have implemented the 99421 to 99423 billing codes. And these are the commercials and these are the billing codes for Medicare. But this is where you're billing for portal messages. Cleveland Clinic got a lot of press on this a couple of years back. When they turned it on, many organizations have turned this on. And this is a way that you can bill for your more complex in-between care when patients are taking time. It's usually 5 minutes or more time that's taken. Telephone care, and here's some kind of portal message requirements. So check with your institution. Patient initiated. They can't have had another E&M code in the last 7 days for the same complaint. They could have seen cardiology, but for you, you can't say, I'll see you tomorrow in clinic and bill them for the portal message. Billing is based on time alone, not on complexity, and minimum 5 minutes. And then evaluation and management is performed. So there's just some documentation requirements that have to go in to be able to submit this to insurance. Any telephone care. So when a patient asks to speak with you and you aren't going to set up a visit, you can do a telephone-based billing code, which is a 99441 to a 99443. And then there's a Medicare specific code called a virtual check-in. So this is a communication initiated by the patient. Provider can respond by phone, text, portal, email. So basically any communication that the patient sent in, either in writing or through calling. And this is a virtual check-in code. This is a G2012. These are just asynchronous codes that you can use as you're taking care of complex patients. I'm not going to spend too much time on this, but there are opportunities to do chronic care management codes, which essentially is a way that you, as a physician or a non-physician provider, or your clinical staff, this is your nurse, this may be your medical assistant, can start to capture the time spent on these chronic complex patients in between E&M codes. So it's time spent outside of face-to-face visit. There are two forms, and there is a resource down here. There is a PCM and a CCM. This is more of the CCM. So this is 2 chronic conditions expected to last at least 12 months. So the example of my patient that I gave is a Crohn's disease patient that is on immunosuppression. Those are 2 diagnoses that is chronic conditions that the patient will have for the next 12 months. The patient has to consent to enroll in a chronic care management program. You can bill at least 20 minutes or more of care coordination a month. So 20 minutes plus qualify. And then discussion of enrollment must occur. And then the code is billed as a part of initiating that visit. So it's a process, it's a workflow. It's not something you're going to turn on. But it is something that you're going to want to turn on. If you are taking care of a high volume of complex patients in your practice, it is something to discuss as a leadership team or with your leadership team, whether or not you've all considered turning on chronic care management codes in your practice for basically billing for your clinical staff's time. Your time also is part of this too, but mainly it's to capture your clinical staff's time.
Question there. So if it's billed by the clinical staff, not providers, who gets the credit? Does the physician get the work RVU? So that will translate into their personal compensation, or the organization gets the capture, date?
I think that that's probably something that, as you would potentially develop this within a practice, we have not turned this on at Mayo Clinic, but if you were to develop this in a practice, that could be something that would be negotiated. Maybe there's a percentage of that would go to the treating physician versus does this go to the practice and does this help maybe augment and hire a nurse coordinator, right? Because you're able to actually capture a bill for her time. So maybe it's just a way to actually quantify the time that your team is spending caring for these patients. But people have to calculate their own time spent. So they'll say that they spent 5 minutes in this, in this encounter. I spent 25 minutes on the phone with the patient. This would be my nurse's documentation in this particular situation. So good question. Okay, so we're going to spend the last 10 minutes talking about endoscopy. So endoscopy basics, more complex than E&M billing because there's just so many codes. Many practices have, a designated, billing team that's associated with endoscopy because that's where the greatest revenue is in our practice, is coming from our endoscopy units. You should make sure that someone is checking your billing and your coding, and maybe you have done an audit on this to ensure that you are doing it accurately. I will tell you, there are times that I get emails saying that whatever was documented was not appropriate to support a submitted code, or I needed to change some documentation to do that. If you are in a procedural or RVU-based practice and your reimbursement and your take-home pay is based on the procedures that you do, you may want to be tracking your own and then ask for a productivity report and make sure that these things are aligned and that you're getting paid for the work that you're doing. Of course, underbilling, you get paid less money, but it's also fraudulent to underbill, and then overbilling is considered fraudulent and will get audited by payers. So endoscopy documentation is easy as 1, 2, 3. Stating your indication for the procedure, it's usually built into most reporting systems. Capturing and documenting all billable work that was completed during that procedure. Optimizing your modifier. And then 4 is providing random procedure documentation and billing audit, is just to kind of make sure that from a practice standpoint, on a practice leader standpoint, making sure that our providers are providing accurate documentation. So that's usually done from the coder side, saying, okay, we're going to audit these particular procedures and make sure that the documentation is accurate. So clearly stating the indication, screening colonoscopy, high-risk screening, surveillance, or was it diagnostic? Capturing all your billable codes. So a biopsy example would be a CPT code of 45380. A snare polypectomy would be a 45385. Multiple technique rules. If you do different things in the colon on different lesions, you can bill multiple codes. So other things would be like a tattoo for lesion localization. Really optimizing your billing codes for EMR when criteria is met for EMR, and I have a slide on that. If you're doing therapeutics, dilation during EGD, and of course there are some therapeutics, and Dr. Shen does a lot of different therapeutics that may not actually have billable exact codes. And so he's probably documenting more based on the complexity, and I'll talk to you about the modifier 22. Whether hemostasis was needed or required, and whether you did submucosal injection that was separate from EMR. If you're in a practice that's based on coding and billing collections, you might get the first code plus potentially half of the second code for that. If you're RVU-based code, your practice may actually give you credit for each code that you've performed in terms of our RVU-based reimbursement. So EMR, as promised. So what are the things that are required to bill for an EMR, and why is that important? Well, EMR can pay you at a work RVU rate of 6.04. Sometimes that doesn't necessarily, depending again on how you're going to get reimbursed. It may be better to document a multi-code reimbursement because it depends on if you get the reduction. So again, the idea of an EMR is a higher single code, 6.04. You have to identify and demarcate the lesion. You have to state that you did submucosal injection to lift the lesion, and then you have to say endoscopic snare resection. That by definition meets criteria for an EMR. And so this would be an example of documentation in that particular situation. And so those are highlighted for you. This is mainly for your reference in the past, or in reference to look at it. Now, depending on collections in your practice, you may decide that actually it's more financially feasible to do snare and injection separately, knowing that you do get a reduction on the second code.
Jami?
Yeah.
Question is, sometimes we remove the tiny polyps with a hot biopsy or cold biopsy, cold excisional biopsy. We still call it polypectomy, like a excisional biopsy with a polypectomy. Versus a snare polypectomy, their reimbursement is the same?
In terms of polypectomy, yes, the codes are different.
Codes are different with the excisional.
A snare code and a biopsy code are different CPT codes. Here's an example right here. I did a biopsy of a polyp and I did a snare polypectomy in the right colon, and I biopsied a polyp in the left colon, and I'm billing both a 45380 and a 45385.
So you can do the both of the, here's the biopsy, including cold excisional biopsy to remove the small, tiny, like 3 millimeter
It
polyp.
doesn't matter if you biopsied for diagnostic purposes or you biopsied a polyp. If you biopsied, the CPT code is the same.
But it's
Well,
like, yeah.
Well, polypectomy itself is not a technical term for billing purpose. They go by device, which device you use. Biopsy is a biopsy, whether you call it polypectomy or just tissue sampling.
I see. Okay,
It goes by device.
Okay.
Okay, this is a busy slide, but meant to be kind of a resource for you. I'm not going to go through all of them, but these are different modifiers that can go onto CPT codes when you're billing based on something that happened. So an example would be a screening colonoscopy started as an average risk screening, then a snare polypectomy was performed. These are often happening on your back end. Your billers are usually adding these particular things, but if you ever were wondering what they were, this is the coding that happens. The modifier that I do want to tell you about, so these are the modifiers. Now, if you did an incomplete exam, oftentimes that automates based on your reporting system to reduce services. So if the exam you didn't get to your intended extent, that would be a reduced services, and that has a modifier based on the payer. Medicare is the asterisk on here. The 22 modifier, this is an opportunity to get paid for complexity of work. So 22 modifier is unusual procedural services. It indicates the work is substantially greater than technically required or typically required. So it's technically a very difficult exam. There was a very sick patient. This was a very sick patient with significant comorbidities and increased intensity of time. The thing that most advanced endoscopy procedures will qualify for 22 modifiers. I will tell you that different geographies and different states and different payers have made different arrangements with organizations of when they can bill a 22 modifier. I'll give you an example of a previous organization where we did a 22 modifier when patients had certain comorbid conditions. That qualified as a 22 modifier with a particular payer. The modifier requires additional documentation. So the most common mistake made here is that this is all true, this all happened, but you didn't document any of the things that were needed to be able to capture that 22 modifier. And it is associated with some reimbursement increase based on the complexity of the procedure. So those are the ends of my slides. I did want to raise awareness of the Tri-Society coding article that recently came out in the last, I think, couple of weeks. And it just really highlights some of the changes that have happened in 2026 in our practice. So there's a new billing code, CPT code for endoscopic sleeve gastroplasty, which is, I think, a huge win for our colleagues who do those types of procedures. There's some updated colonic motility codes. These are usually interrectal manometry codes in your practice. And then new category codes for things that I didn't realize that gastroenterologists were doing in high volume, but that's part of the updates. And then it also said to raise awareness again of going back to, it's the 5-year anniversary of some of the billing changes that happened in 2021. It did make you think that there were a lot of changes that happened on the clinical E&M side, and that's just not true. So we're still doing a lot of the same things we were doing since 2021. It's a nice 4-page read Tri-Site article. So that's linked on this slide for your reference and resource as well. So with that, some take-home points. Your reimbursement is directly tied to your knowledge around clinical and procedural billing. You've already, being here tonight, I think has already helped you be one step ahead of your colleagues. Documentation accuracy is the most important aspect to ensure appropriate billing and reimbursement, both in clinic as well as in endoscopy. A few changes you can make some major impact in terms of your billing and reimbursement. Bill for time spent. If it's not the highest level, then move on to MDM. Don't forget your G2211 in appropriate patients. Sounds like Jim is using this quite frequently over there in Seattle. Consider an e-visit workflow billing if you're not already doing this in your organization or in your practice. It's not necessarily tied to significant reimbursement and pay for the practice, but we did show and published recently at Mayo Clinic that we were able to reduce volume of messages by 10%. And when you know how many messages we get, that's actually a huge win for our teams. chronic care management opportunities could be some workflow changes that you have to kind of capture those complex patients and that longitudinal care that happens asynchronously outside of your clinic visits. And then if you're not using a 22 modifier, it might be a good idea at a practice level to assess how many providers are using it. If there's not, there may be a push to try to use it because it is something that is routinely appropriate in especially complex endoscopy. So with that, I think we have a minute or two, I guess, for some last minute questions, but I'm also, I'll put my email in the chat if anybody had any offline questions. I'm happy to answer them.
Yeah, I have one quick question about the endoscopy coding. I don't know what you use at Mayo Clinic. In our group, we use Provation. So we pretty much used automatically codings generated by Provation and submitted to the billing department. In your experience, does Provation do a good job? By what percentage?
It's a really good question. So we recently at Mayo, we went live 6 months ago at Florida, and then we just went live in Rochester with Lumens, and I had the opportunity to lead that effort. And we have found that our accuracy has improved since changing over to Lumens. So I think that there's some opportunity there, and it may be because the documentation is so ingrained within Epic, and so it's not external to Epic, and it's much easier to document those modifier 22 requirements because we've baked it into the Lumens report. But we've gone live with Lumens and it's gone really well. So we are capturing, I think, more revenue with Lumens because I think we're making it easier to do the documentation. That's not to say that people are missing significant revenues out there. And I see my colleague, Dr. B, come on too. So I think that there's some audit opportunity with information. And I know many institutions are making decisions whether they're going to get Apex or Lumens. I do not get paid by Lumens.
One other quick question about the trainee coding modifier, GC. Do you have to make the statement you agree with the trainee because you made some modification in that note? You don't always say I agree everything that's said in the trainee's note.
I think you have to attest the note.
Okay, so that's a requirement.
Yeah, there has to be an attestation from you, and many trainees, depending on if they have a visa or not, can bill independently. There are some rules around trainees billing independently if they are here on a training visa, which there's far more complex in this conversation today. But some trainees can bill independently, even if you were involved with it. But we attest anything that we've done and seen with a patient or with a trainee or discussed with a trainee.
Jami, so when we perform the endoscopy, right, we do the physical exam at the time of the procedure before 30 minutes before the procedure. This and also our institution required write an H&P before the procedure.
You cannot bill for that.
You cannot bill, okay.
No, because it's required for you to have done it. Now, if you saw them as a separate evaluation and management in the clinic, and then you brought them to endoscopy, then you would use a 25 modifier on that clinic visit. But for that quick, hey, how are you? Do you have any comorbidities? Listen, heart and lungs, press in the belly, open your mouth. Yeah, and we that's kind of bundled as part of that, and it's required to provide sedation.
I see.
Yeah, like Dr. Kinnucan mentioned, the only exception is for inpatient on the new visit. On the same day, you can charge for E&M and the procedure.
Thank you. So another thing.
I have a quick question, please. Sorry.
Go ahead.
Oh, thank you. Sorry to interrupt you here. Didn't realize you had another question. A quick question regarding the portal message billing. I think you brought up a great point there. You indicated that if the portal message is initiated by the patient and then we respond, there's a code that we can use as per your slides. If we respond to the portal message and then that is further sent on to the patient by our staff, is that still something that is considered billable? Because yes, I am the one who responded to the patient and then indirectly is being forwarded by my medical assistant, etc. Thank you.
We developed this workflow at Mayo Clinic, and I had the opportunity to develop it as well at Michigan. And so it typically, it's a little bit nuanced. You have to, since you're the one that's submitting the code, the patient sends a message into your staff. Maybe your staff does some maturing message. They provide you with some labs, their recent visits, you review it. There really needs to be a communication from the billing provider back to the patient with the recommendations. And then there's some documentation that's required in the record of time spent. This is a patient-initiated portal message. There has to be consent. And so organizations have done two things. One is there's something called active consent. So I'm about to send a portal message and I click a box that says I'm okay with that there may be a bill submitted to my insurance for digital care. I think that's one of the languages that's been used. That's active consent. I clicked the box and sent the message. Passive consent is what we've decided to do at Mayo Clinic and many other organizations, which is that at the disclaimer on your EHR app, where I'm about to send that message, underneath it says that the time required for your provider to respond to this message may something will be submitted to your insurance for reimbursement. And so that's passive consent. It's the patient didn't check a box, but the disclaimer is there. They read it and then they still sent the message. So that's passive consent. But there has to be some sort of indication that you've connected with the patient on this. So the same thing would happen with telephone care. Patient calls in and says, I want to speak to Dr. Kinnucan directly. If my nursing team would say that Dr. Kinnucan, we either set up an office visit, which is actually higher reimbursement. But if I didn't have that opportunity and we needed to connect, if I called the patient, they'd say, there may be a bill submitted for your insurance. Most patients are okay with that. They want to receive that care. And we have found that it has not impacted our patient experience. And that's been published by other organizations as well.
Jami,
Thank you.
why did they use the AI for colonoscopy? Is it additional code or not?
Oh, no, there is no additional code reimbursement for using the artificial intelligence on withdrawal.
Not
That's
yet?
sort of the big controversy, right? Because it costs more to have these machines.
Yeah.
But that it's like there's nothing that we can bill extra for it.
I see.
At least not yet, but maybe as an organization or the tri-sites can get together and I bet the insurance says it's, I know it costs more money for you all to have those. It increases your, maybe you're billing more because you're finding more.
Yes, right? Reminding me,
but now you're billing for a snare polypectomy and a colonoscopy instead of just.
I do find out that the AI increased at least like 50% the number of the polyps, So it's also I do if I treat a stricture, I use endoflip through the anus, the distal bowel, and the endoflip can be built separately. Of course, before you do that, we need to get informed consent, so the endoflip can be built separately. Yeah. Okay. Wonderful.
I have a question.
Yeah.
Okay. Thank you, Dr. Kinnucan. Very good talk. So for the modifier 22, if you have a patient who has a severely tortuous redundant colon that requires you to change position, can you bill that for it?
You can. You just have to document it. That
Okay.
This procedure was substantially more difficult. So the way that we've built it in is that if we click the button in the Lumens report that says substantially more difficult, it requires me to pick why. And then that substantially more difficult button will trigger our coders to add 22 modifiers. They'll review it, they'll make sure the documentation is accurate and then and that it's enough documentation. I will tell you that there are times they'll send it back and say, can you please document why this was substantially more difficult to be able to qualify for 22 modifier?
Okay, thank you.
Jami, follow up on this question. I think the provision has the difficulty procedure. I don't recall the Lumens has that box for us to click, do we?
Yeah, it's on the right side, on the right side of the reading macro.
Okay.
It's like not difficult, something difficult, and then substantially more difficult. That's what the wording is used, and it goes into the report. And it triggers now automatically the 22 modifier, where in probation, you have to click it. Everything else is automated in probation, but the 22 modifier on that billing screen requires you to click that modifier.
Jami,
Hey, it's Iris. Just to clarify on
Iris.
that point. So moderate difficulty does not trigger the 22 then? It has to be substantial?
Substantially more difficult.
Got it. Got it.
For the timing, right? So sometimes, some procedures are so challenging. Probably you spend 1 hour trying to finish one colonoscopy. Based on time per se, that must be a very challenging case. So, but that does not represent if you don't click the.
You have to click the substantially more difficult. Yeah.
Mm-hmm.
So it has to have that documentation and language. Otherwise, insurance will deny the 22 modifier. And the benefit is that there's significant revenue opportunity there. So you just have to train your teams. And so we've been capturing, Jan, when we've been looking at reporting since going live with Lumens, the percent increase in 22 modifiers because we're making it easy, right? Before it's you have to remember to do it. Now we're making it easy and it's automatically triggered.
So 22 modifier actually for the people with the bowel surgery is additive. So at the stomach surgery, my coder expert just several months ago told me about like, for example, if I dilate the stricture of the people with the ileostomy, then you can use the 22 modifier. So if I do the balloon dilatation for the ileal pouch stricture, they are allowed to do the 22 modifier because I cannot build up the colonoscopy with dilatation. Is this probably this is true, right, Jami?
It can be. It can be very payer dependent. When I was at my previous organization, somebody having a BMI that qualified them as obese for one particular payer meant we could bill a 22 modifier on them. And since
I see
that's a lot of the population, I was surprised when I came to Mayo that that was not the case with the payers in Florida. And so it can be very geographically dependent, but there's a resource here at the bottom, modifier 22 do and don'ts. Really what it is it's you have to document that the work that was required is substantially greater than is typically required. So a routine pouchoscopy, though, is a very standard exam. It's usually about 10 to 15 minutes.
I will talk
Needle
about
knifing a stricture is a substantially more difficult procedure than a routine pouchoscopy. So I would agree with you that would meet that. You just have to make sure that the language that you're using is qualified.
Yeah.
Well, great. I thank you for spending your Sunday evening with me. I really hope all of our friends on the East Coast are safe and able to get where they need to go or stay home safely over the next 24 hours.
Dr. Kinnucan, this is the best by far.
Oh,
coding lectures I've attended. I am so well educated now. I feel like I wonder if I could share some of your slides with my colleagues.
I would love for you to. I will send a copy of these slides and make sure all the links are working so that you all can send them out to your organization, as well as if you wanted to share them with colleagues. I'm more than happy to do that.
You're so generous. Thank you. My colleagues would love to see these slides.
Yeah.
Thank you, Jami. This is like on behalf of what we call Chinese American Gastroenterological Association. Well, thank you and for the opportunity. But to give the lecture. In the meantime, and in the future, if we have some other organization, there's for example, there's a North American Chinese Alliance of the Chinese Physicians. If you can give the similar lecture to
I'd be happy to. I think most of these lectures are given by coders who are non-clinicians, and it can be very challenging to follow some of those. I've sat in them, and I know a bunch about this, and I've been more confused when I've left. So I got into this because I thought there has to be a better way that we can educate people, clinician to clinician, as opposed to somebody who's very smart in that space and can probably answer some nuanced questions, but doesn't know the clinical side of practice. So,
thank you.
All right. Thank you. I hope.
Thank you, Jami. Excellent talk. I feel so lucky I'm working with you here at Mayo.
Thank you, Jami. Talk to you soon. Take care.
Thank you.
Bye-bye. Bye, everyone.